So ALL is the most common malignancy in childhood, and one of the most common toxicities that's become a rate-limiting toxicity or treatment-limiting toxicity for patients is osteonecrosis or avascular necrosis, AVN. And so what we sought to do is look for the genetic risks for the development of AVN in patients who are treated for ALL. And to do this, we gathered a cohort from the Children's Oncology Group, who we collaborated with, and looked at the genetic variants that those patients inherited across 2 different protocols. A protocol for patients with standard risk, or NCI standard risk leukemia, and a protocol for patients with high risk leukemia. And we found some unique genetic variations that hadn't been found previously. The variations included variants in the gene BMP7, or bone morphogenic protein 7, and this is a gene that affects the balance between development of fat within the bone and the development of the bone itself, and then also variants in a glutamate receptor called GRID2. And so glutamate, we think, is important to osteonecrosis for several reasons. The first is that we know it's toxic to the vasculature, and we think that the reason that osteonecrosis develops is damage to the blood vessels just prior to the bone, and so it actually starves the bone of nutrients and oxygen. The other issue in glutamate receptor signaling is that we found in a recent analysis of a large population that included 2 ALL cohorts, as well as a group of patients who received glucocorticoids for other reasons, that glutamate receptors were the key in the development of osteonecrosis in that population. And so we think that we've validated those findings by finding this in another patient population, and then also discovered some new biology in terms of the way that bones are forming that may result in osteonecrosis. Yeah, so our future directions include further evaluating these variants that we found in the laboratory, and we want to do sort of 2 parallel experiments. The first is try to verify some of these findings either in an animal model or in additional patient cohorts to make sure that they hold up as we change details of treatment, as we change some of the details the patients receive. The other thing we need to do is make sure that these variants also confer additional susceptibility in the leukemic cells to the therapies we give, because we don't want to back off on therapy if it's only the patient that's going to be harmed if the leukemia is able to still resist those treatments. So we've got excellent cure rates for ALL in pediatrics, greater than 90%, and we don't want to back off on therapy if it means backing off on our cure rates, even if we would get less side effects. So hopefully what we'll find in our experiments is that we validate these findings in the clinical lab, or in the lab in our animal models, for example in the mouse, and that at the same time the leukemic cells that are in that environment, either because they've inherited those variants or because the tissues around them inherited those variants, are more susceptible to treatment. So we'd be able to then, in that context, give less treatment, still achieve cure, and hopefully give less toxicity to our patients.